So we'll try and muddle through as best we can. If you've got any questions, just ask. We're all here to help, basically. So we're going to cover the respiratory OSCE this evening, but before we start, just a few words of reassurance, really. The three of us were sat where you were this time last year, worried about all the books to read, all the stuff we didn't know. And the fact is, for the OSCEs, it's just about repetition and getting into the routine. The exam isn't as bad as you think it's going to be. All the doctors there want you to pass. They're giving up their free time to come and examine. And the case is, especially for respiratory, you're not going to get really sick patients. So, even if you're trying to guess what's going to come up, it's going to be fairly predictable. They're going to be stable patients in the community. Your COPDs, your bronchiectasis. You're not going to get someone with, pulmonary edema that's really sick. So that can help you kind of break down your OSCE revision. And just a word about getting to this stage next year. F1's brilliant, so just hang on in there, and you two will be giving this lecture this time next year, hopefully. So, important bits about the OSCE is, you don't actually need to know too much medicine. There's things you can go over and over that anybody can do. So just the basics of washing your hands, being really nice and friendly and polite, smiling, making sure you get permission to do everything, making sure the patient's in the right position. It's a bit of a game OSCE, so kind of move the bed around so it's not convenient, or you'll have this little old lady with a cardigan on, a thermal vest, a frilly bra underneath, and the point is you've got to make it easy for yourselves. Be gentle, causing patients harm isn't going to get you many marks. And look professional, don't walk in there looking really anxious and worried. You do know enough even now, so just go in there with the confidence and, pull off being a doctor. So before you go near the patient, really obvious stuff, but it's just so easy to forget in the heat of the moment. Read the station instructions, and it's a bit of an act. You've just got to put your game face on, go in there, introduce yourself, and carry on like that. So it's all autopilot. You must have done loads of exams on the wards. There's always medical students on vascular going through the motions, and that's exactly what it is. You know how to do the exam already. Hopefully this is just going to summarise it and, give you some reassurance. So it's all about being systematic, starting from the hands, working all the way around. If you forget any bits, that's absolutely fine. Make it look as though that's part of your routine anyway. And practice saying things out loud as you're going along, but also practice doing it so, you just mentally clock up all the signs and then present it all at the end. And then no matter what you're asked for on the day, you're prepared for it. And videoing yourself's really useful. The first time that I did it with my friends, it's painful to watch all your embarrassing habits back, things that you don't even notice, but there's so much you can learn just from watching yourself. Look what looks awkward, or things that you say a few too many times. And just keep practicing. So the first thing about respiratory is you can pick up so much before you have to listen or worry about what the diagnosis is. The first thing is just to step back, think about it, and just see what can I see here. So from the end of the so it's a bit like your driving test. You're looking at all the mirrors, saying what you can see and what you can't see. So your peak flow meters, your inhalers, sputum pots, cigarettes, something as basic as whether the patient's on oxygen, whether they've got a SATS probe, any steroid use, just have a look around. Even if it takes you 30 seconds, it's time well spent, because it will just give you so many clues. And then lots can be gained from looking at the patient really closely. Do they look healthy or do they look quite sick? Are they cachectic, wasted? Do they look as though they've been on long-term steroids? What does their breathing look like? Are they panting away, or do they look quite comfortable at rest? Look at the chest. Is it looking symmetrical? Do they have any deformities, pectus excavatum or carneatum, any scoliosis that may affect their breathing? Do they have scars? That's going to give away quite a lot. And is the breathing noisy? So already these are so many points by knowing no medicine, just having a checklist in your head. So start to make it easy for yourself. Make sure you expose the patient. Don't be embarrassed about it. You can't go feeling around jumpers. If the examiner doesn't want you to take something off for whatever reason, they'll stop you, but make sure that you're in the best position for it. Make sure they're at 45 degrees and ask before you touch anything, do they have any pain? So now we're still on looking, we're looking at the hands. Is there any clubbing? Is there any tar staining? Remember, nicotine's a colourless substance, so it isn't nicotine staining, it's the tar. Is there any small muscle wasting? Do they look peripherally cyanosed? And does it look as though they've been on steroids, or they've got kind of thin, papery skin? And then you want to look if they've got a flapping tremor, so ask them to extend their hands and have a look. And it's not a 2-second job, you've got to look for a good 10 seconds. Take the radial pulse, make a note of its rate, its rhythm, its character, and whilst you're doing that, count the respiratory rate. Again for about 30 seconds. So just as a bit of an aside, if you see fingers that look like that, and I showed you this x-ray, is there anything other than just simple clubbing that it could be? It did say on the last slide actually, I put that in the wrong place. So if we just go back, it's called pulmonary osteoarthropathy, and it's to do, if you get certain types of lung cancers, it can cause a type of clubbing, and you also get this kind of extra bone formation, so you can get kind of swollen ankles and just extra bones laid down. But anyway, that's extra stuff. So yeah, associated with pulmonary adenocarcinoma. So the respiratory causes of clubbing, they always like to know little lists. So lung cancer, mesothelioma, bronchiectasis, cystic fibrosis, and empyema. And some people want to know the 4 stages of clubbing, so just make sure you can rattle those off. And again, don't just have a quick glance, bend down, have a proper, it's such a big act. Have a look, have a feel. Even though you feel ridiculous, it's exactly what they're looking for, a thorough examination. So then, after the hands and the wrists, we go up to the face, so look in the eyes, look for pallor of the conjunctiva. Some people do this twice, but you never get unilateral conjunctival pallor, so you just need to look in one of them. Have a quick look at the pupils for Horner's syndrome. Look at the lips and the mouth. You want to know, if they use steroids and they're not washing their mouth out regularly, you can get candida building up. Look for central cyanosis. It's probably not going to be there because you need to have quite a big desaturation for that to show, but again, it's important to say no central cyanosis. Do they have cushion-eye places? Look for that. Have a look in the neck for the JVP, and any tracheal deviation. And we'll have a chat about what they signify in a bit. So again, just as a quick aside, Horner's syndrome. So Pamela Anderson, quite, horny. So that's the mnemonic to remember it. And that's quite interesting, again, from a lung point of view, because of the apical tumours, your Pancoast tumours, that can invade the brachial plexus. And obviously, Horner's syndrome is when you get invasion of the sympathetic chain, which lies close to the brachial plexus. So have a quick read up about that, because it sometimes comes up in your written exams. And then, so you've done the face, you've done the neck, and you're down to the front of the chest. So again, it's about really, looking really carefully. So pacemaker scars, cardiac and respiratory do overlap quite a lot, so again, just have a look out for it. The middle one is a lung transplantation scar going all the way across. The picture down there shows distended veins across the chest, so that can often be superior vena cava obstruction, again linked to malignancy, and you've got a lateral thoracotomy scar there. So again, it's good to have a look at the chest, ask them to sit forward, can you put your arms up for me? Because you're not going to see any lateral thoracotomy scars just sat like this, so have a proper look around. And then you're down to the bones of the respiratory exam really, so you're on the front of the chest. Remember that you've got 2 lobes on the left, 3 on the right. Always talk about them in zones though, because you're not going to be able, when you're examining, you can't pick up which lobe things are in, so talk about upper zone, lower zone on the left. So you want to feel for expansion, don't be shy, get your hands, have a good, make sure you've got a good grip and feel in 2 places for a decent chest expansion. Comment if you don't think it's symmetrical. Also have a feel for the trachea, make sure it's in the middle. It's unlikely to be deviated in your OSCE exam with your stable patient, but again, it's an important negative. And have a feel for the apex beat as well. And then you're onto your percussion. Make sure you have a good percussion note, no whimsical tapping away, And you're comparing like for like, so don't work downwards, work across and compare. And you want to feel in at least 3 areas. And don't forget the axilla as well. So start the clavicles, work across. And there's only 4 possibilities it can be. It can be resonant, which is normal. It can be dull, it can be stony dull, or hyperresonant. And, from that you'll pretty much pick up what the underlying pathology is. So make sure you go onto respiratory wards and, listen while you've got time to what those different sounds sound like. And then you want to listen as well, so start high up, compare like for like, and listen in the axilla as well. So that's just a quick chart you can look at later about, the different pathologies and the signs you'll get. In my OSCEs, I didn't actually have to do tactile vocal parameter, so I don't know if you guys do, but that's another sign you can pick up on, not too specific. So you've done the front of the chest, and now you're working towards looking at the back. So you want to rattle through the early stages of the respiratory exam quite quickly, because that's where the money's at, on the back. That's where you're going to really hear the signs, see the scars. So to make it look slick and to stop you sitting the patient up and down, after you've finished on the chest, before you get to the back, quickly examine the neck. So this here is where they've done a lymph node biopsy, so that's the scar in the neck. Have a quick look there, and have a quick feel for lymphadenopathy as well. And then, as I said, you get to the back, which is where you're going to find the important bits, really. Again, have another good look before you start anything. If you forgot to look for the thoracotomy scars. Look for any radiotherapy causes quite a lot of damage. You often get kind of skin marking from that, so worthy of comment if you see it. Feel for expansion again. Percuss like for like, all the way to each side, all the way down. Do your tactile vocal parameters if you guys do that in your exam. And again, have a good listen. Don't rush through that. Spend a good 10 seconds on each side really listening, deciding what you can hear. And remember that you're on the back, the lobes that you're actually listening to, the left lower lobe and the right. If you hear some noises, get them to cough, because again, that's an important distinguishing factor, which we'll talk about in a couple of minutes. So this is where you want to spend most of your time. I'm not sure, how many minutes do you get for your examination stations? Okay, so that's a decent amount of time. You don't need to rush too much. So make sure you get to this bit fairly quickly and spend your time here. And then to finish off, you're going to thank them. You're going to help them get redressed, wash your hands, sigh of relief while you quickly put together what you think you've found. And then the standard, you want to finish by taking a full history for the patient. You want to look at the OBS chart, you want to do a peak flow, and you want to review any chest x-ray or maybe spirometry. And then it's time to present your findings. So you want to point out the salient features. You don't want to go through absolutely everything. There was no this, there was no that. Point out the important things. So, if you're examining my chest, you'd say, I examined this lady's respiratory system, comfortable at rest, no medications or monitoring around the bedside, no peripheral stigmata of respiratory disease, chest expansion equal bilaterally, resonance to percussion throughout the chest, air entry was equal, no added sounds, consistent with a normal chest. And if you get used to practicing those kind of spiels for different pathologies, then you'll just look really slick at the end and not looking as though you're trying to put all the bits together. So let's just be these. Let's talk about, you've cheated, what these could be then. So say you found clubbing and coarse late inspiratory crackles, which changed on coughing. I know you've seen the answer already, but would you have said bronchiectasis? Okay, well, we'll say you would. So you've probably read all the books already. So your normal lung parenchyma gets destroyed and you get this widening. So when you cough, 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 you clear the mucus temporarily, and that's why it changes when you're listening. What about this one then? Clubbing plus fine, mid to late inspiratory crackles which don't change on coughing. Fibrosis, yeah, so it sounds like Velcro, supposedly. So yeah, when fibrous connective tissue replaces normal lung. So know about most of it's idiopathic, but sometimes linked to interstitial lung disease. So what happens if you can't hear anything and there's a scar? Yeah, and indications for that? Cancer, anything else? Old TB, they used to chop the lung out. Good. What about dullness at one of the lung bases? I just heard. Any more specific answers? Okay, anything, what would your differential be? Consolidation and effusion, yeah. So, yeah, fluid collection or... And interestingly, it's supposed to be the tactile vocal remedies which helps to distinguish these two. Because if you've got the effusion, which is on the right-hand side, it kind of pushes the lung up, which is why it's stony dull. Whereas, you know, if you've got lung tissue there, which has just mopped up a bit of infection, then it sounds different. So have a read up about that. And I've heard that sometimes you can be quizzed about, you know, seeing different pieces of apparatus. So I just thought these are some of the respiratory ones. So I just wondered if you knew what all of these were. So if we start top left, what are all of those? Okay, what about the middle one? Far. Yeah, this one? Yeah, what about the blade? What's its specific name? So it's called a Macintosh blade, used for the ET tubes. The machine is a... And the far one over there? Good stuff. So then, just a quick recap then. So just take your time having a really good look, because there's so many marks, so many respiratory things you can pick up. Look around the bed, your inhalers, your oxygen, your sputum pots, devices and medications. Have a really good look at the patient, because it just gives, you know, they give so much away. Are they there short of breath, wheezing, cyanotic? Look at the accessory muscles of respiration. Are they edematous, cachexic? What's the respiratory rate like? Is it really noisy, rattly breathing? Have a really close look at the hands. Are they clubbed? Are they stained? What's the temperature like? What's the skin condition like? Look at the CO2 flap, the pulse, the face and the neck working up, pupils, the conjunctival pallor. Have a look at the neck, at the JVP, any lymphadenopathy or tracheal shift. Look at the chest at the front, any scars, any radiation damage, what's their expansion like, feel across for the percussion. Note the timing of any added sounds, are they in inspiration or expiration. Quick neck exam, and then most of the time spent looking at the back. And then the finishing touches, the extra things that you do or tests you'd want to run. So that was I know that's quite a quick rundown, but ideally it would be great if some of you guys could practice at the front, because like Shana said, if you can do it in front of this, then your OSCE's going to feel like nothing on the day. So we'll build this into a scenario. So we're talking about a 75-year-old lady who comes in short of breath and a productive cough. She's got a temperature of 38.2. Is there anybody that would like to do that respiratory exam on a pretend patient?
Oh, come on.
Nobody wants to give it a try. It doesn't matter if you get it wrong.
We'll all chip in.
Shouldn't really. I'll be up. I'll volunteer.